I am about to tell you what is happening inside the brain of every senior who has been on metoprolol for more than 5 years. It is happening right now while you watch this video, while you struggle to find the word that used to come instantly, while you sit in a room and forget why you walked in, while you feel that fog behind your eyes that rolls in like clockwork every afternoon and makes you wonder if this is how it begins. Your doctor knows about the fatigue. They call it a common side effect of the beta blocker. What your doctor has not told you is that the fatigue is not the problem. The fatigue is the alarm. And what that alarm is warning you about, what is happening quietly inside your brain tissue with every pill you swallow, is the reason I could not wait another day to make this video. Metoprolol is the second most prescribed drug in the United States. More than 34 million Americans take it every day. Your doctor chose it because it slows your heart rate, it protects against another cardiac event, and it keeps the number on the chart looking controlled. But there are 5 things metoprolol does inside your brain that your doctor has never walked you through.
Because nobody has time in a 7-minute appointment to explain what a pill does to the organ you think with over 5 years, 10 years, 15 years. Your doctor sees you for 7 minutes every 90 days. The pill sits inside your blood-brain barrier every single hour of every single day. By the end of this video, you will know exactly what metoprolol is doing to the neurotransmitters that control your mood, and why the sadness you have been calling just getting older is a chemistry problem, not an aging problem. You will know what it is doing to the part of your brain responsible for memory formation, and why the word-finding failures and the forgotten names are showing up on brain scans, not just in your daily life. You will know the one conversation with your doctor that catches the brain damage early, before the medical system stamps the word dementia on a chart that never asked about your pill list. You will know why the sleep that used to restore you no longer does, and what metoprolol is doing during the night hours that steals your rest without you knowing it is gone. And you will know the exact alternative that does the same cardiac job without crossing into your brain, and the exact words to say to your doctor to make the switch before another year passes. If you are on metoprolol right now, I want you to do something before I continue. Think back to the person you were before you started taking this pill. How quickly did words come to you? How well did you sleep? How interested were you in the things that used to make you want to get out of bed? Now think about you today. If there is a gap between those two people, if you have been quietly grieving the version of yourself that felt sharper, more alive, more present, I want you to understand something before we go further. You did not lose that person to aging. You may have lost that person to a pill.
Margaret walked into my office 14 months ago. She was 73. A retired journalist from Cincinnati who had spent 40 years asking precise questions and remembering every answer without writing a single note. She was the kind of woman who could hold an entire interview in her head, walk back to her desk, and reconstruct the conversation word for word. She had been on metoprolol for 7 years, 50 milligrams every morning, added after a mild cardiac arrhythmia that resolved on its own within a year of diagnosis, but the pill stayed. When Margaret came to see me, she was carrying a small notebook everywhere she went. Not for journalism, she had retired. She carried the notebook because she was terrified she would forget something important and not know she had forgotten it. She had started writing down the names of her grandchildren, not because she had forgotten them, because she was afraid that one day she might, and she wanted to have them written somewhere safe. Her daughter had Googled early onset dementia symptoms twice in the past 6 months. She had not told Margaret. Margaret found out later when they read her daughter's browser history while they were together. She closed the laptop and did not say anything. She sat with it. Margaret told me that the fog started in year 3 of the metoprolol, a gentleness at first, a kind of softening at the edges of her thinking. She mentioned it to her doctor. He said fatigue was common with beta blockers and recommended she take the pill in the evening instead of the morning. She switched to evenings. The fog moved with it. By year 5, the fog had a schedule. It arrived by noon and did not lift until 8 in the evening. The afternoon hours she once used for the sharpest, most focused work of her day, gone. She sat through those hours waiting for the fog to clear. She napped in a way she had never napped in her life, deep afternoon sleeps that felt less like rest and more like disappearing. By year 6, she had stopped accepting lunch invitations, not because she was antisocial, because she was terrified she would lose a word in front of people, that she would reach for a name she had known for 30 years and find the shelf empty. She described it to me this way. It is like being in a room where all the furniture is covered with white sheets. You know everything is there. You lived in that room your whole life, but you cannot see anything clearly, and every time you reach under a sheet to find something, your hand comes back empty. I asked her how long she had felt that way. She said, "I thought it was just me getting old. My doctor never said anything. He just kept checking my heart rate and telling me it looked good." Her heart rate looked good. Her brain was being changed from the inside, month by month, year by year, and nobody had checked. Let me explain what metoprolol actually does inside your brain, because understanding this mechanism will change the way you think about every pill you have swallowed since your doctor wrote that prescription. When you swallow metoprolol, it travels through your bloodstream and begins blocking structures called beta-1 adrenergic receptors. In your heart, this slows the heart rate. That is the intended effect. That is what the prescription is for. But metoprolol does not stay in your heart. Metoprolol is what pharmacologists call lipophilic. It dissolves in fat, and your brain is 60% fat. This means metoprolol crosses the blood-brain barrier with ease. It does not knock, it does not ask. It crosses and it starts blocking receptors in your brain tissue the same way it blocks them in your heart. In your brain, beta receptors are not there to control heart rate. They are there to regulate a chemical called norepinephrine, which your brain uses to maintain alertness, focus, attention, and motivation. When metoprolol blocks those receptors in your brain, it muffles the signal. The lights do not go out, they dim. Every day the same dimming. Every morning the same blunting of the sharpness that used to be there. This is not a side effect your brain was designed to compensate for. Beta receptors in the brain are not backup systems, they are primary wiring. Muffling them every day for 7 years does not leave the wiring intact, it changes it. Studies using brain imaging on long-term beta blocker users show measurable changes in the regions responsible for memory encoding and emotional processing. Not the same changes as Alzheimer's, not the same mechanism, but real changes on a scan, real changes you can see on the image of a brain that has been under the daily influence of a lipophilic beta blocker for years. Your doctor does not look at your brain. Your doctor looks at your heart rate.
Your heart rate is 58. It looks perfect. Your brain has been running at 70% of its capacity for 5 years, while the chart celebrated the number 58. There is a second mechanism that is even less discussed, and it explains something that millions of seniors on metoprolol have been told is a normal part of aging. The same norepinephrine system that metoprolol blunts in your brain is also a critical part of your emotional regulation. Norepinephrine does not just control attention, it controls motivation. It controls the feeling of engagement, the sensation that something is worth doing, worth trying, worth getting up for. When metoprolol suppresses norepinephrine in your brain day after day, the world flattens. The things that used to make you curious no longer pull at you. The grandchildren's visits are still pleasant, but no longer electric. The book you used to stay up to finish no longer calls you back. The garden you spent 40 years loving feels like a chore. You tell your doctor you feel low. Your doctor calls it late-life depression and adds an antidepressant. The antidepressant does not fix the problem, because the problem is not a depressive episode. The problem is a chemical blockade. You cannot treat a blocked signal by adding more signal from a different direction. The blockade is still there. This is the second prescribing cascade, and it runs in parallel to the one your competitor described with the water pill. Metoprolol flattens your mood. Your doctor adds an antidepressant. The antidepressant interacts with metoprolol, often raising its blood level because they compete for the same liver enzyme. Higher metoprolol level, more brain suppression, more flatness. Your doctor increases the antidepressant. The flatness stays. The pill count rises. Margaret had been offered an antidepressant twice by her previous doctor. She had refused both times. She told me she did not want to add another pill when she did not understand what was causing the problem. She was right. She did not need an antidepressant. She needed someone to look at the pill she was already on.
There is a third mechanism that explains why the fatigue from metoprolol is not ordinary tiredness. And understanding this will explain why 8 hours in bed no longer leaves you feeling rested. Your brain has a sleep architecture, a sequence of stages it moves through during the night that accomplishes specific repair and memory consolidation work. The deepest stage, called slow wave sleep, is where your brain processes the day's experiences and files them into long-term memory. This is where the events of Tuesday become the memories of your life. This is where the learning solidifies. This is where the brain clears the metabolic waste products that accumulate during waking hours. Beta receptors in the brain are critical regulators of this sleep architecture. When metoprolol blocks them, it disrupts this stage sequencing. Specifically, it suppresses slow-wave sleep and increases fragmented, lighter sleep stages that feel like sleep but do not accomplish the deep repair work. You sleep 8 hours, you wake exhausted. You have been sleeping but not restoring. This has a second consequence that compounds the memory problem. When slow-wave sleep is disrupted night after night, the brain's waste clearance system, which runs primarily during deep sleep, backs up. The very proteins associated with Alzheimer's pathology accumulate faster in brains that do not get sufficient slow-wave sleep. The pill that blunts your memory formation during the day also disrupts the nightly process that clears the waste products of cognition. You are not sleeping wrong. The pill is sleeping in your brain at night.
Margaret had been watching her ankles every morning for a different reason than most of my patients. She had read an article about amlodipine side effects, but she was not on amlodipine. She was on metoprolol. She came to me convinced her problem was her heart medication, but could not name why. I asked her to describe her day, hour by hour, from the moment she woke. She described waking at 6:30, feeling as if she had not slept. A 40-minute window of relative clarity in the morning while making coffee and reading. The fog arriving by 11. Lunch alone because she had stopped enjoying the restaurant she loved. The long grey afternoon in the chair. Dinner. Television she could not follow. The notebook on the nightstand.
I asked her when she had last felt consistently sharp. She said, "Before the pill." I know it was before the pill because I remember the last year of my career, and I was sharper then than I have been since. She was on metoprolol when she said that. She had been on it for 7 years. She had been quietly conducting the comparison herself and landing on the same conclusion every time, and every doctor visit had told her the heart rate looked good and sent her home. I ordered a cognitive screening test, not to diagnose dementia, to establish a baseline. Her score was in the range consistent with mild cognitive impairment, below where a 73-year-old journalist with her history and education should score. Not catastrophic, but measurably below where she should be. I ordered a sleep study. The results showed severe suppression of slow-wave sleep. She had been completing sleep cycles, but not achieving the depth the cycles were supposed to reach. She had been sleeping without restoring for years. I ordered a simple blood panel looking at her homocysteine level, an underused neurological stress marker that climbs when brain tissue is under prolonged strain. Her level was elevated. None of these tests had ever been ordered in 7 years of metoprolol. Her heart rate was 58, model patient. Leave a comment right now and tell me how long you have been on metoprolol and whether you have noticed changes in your memory or mood. Not for me, for the senior watching this after you, who has been told for 3 years that what they are experiencing is normal aging. Your comment puts this video in front of them. You might be the only person who tells them this is not who they have to be. There is something metoprolol does that almost no one talks about, and it explains why the side effects get dramatically worse as you age, even if your doctor has not changed your dose in a decade. Your liver clears metoprolol using a specific enzyme. When you were 60, that enzyme worked efficiently. By 75, the liver has shrunk, the blood flow through it has dropped, and the enzyme clears the drug more slowly. The metoprolol from this morning is still partially present when you take tomorrow's dose. The doses stack.
A senior who has been on the same 50-milligram dose for 10 years may be walking around with the functional brain suppression of someone taking 80 or 100 milligrams. The doctor never increased the prescription. The aging liver increased the effective dose silently, year by year. This is why the fog felt worse at 72 than at 65, not because the disease progressed, because the pill accumulated. There are also 2 common medications that senior men and women take alongside metoprolol that dramatically increase its level in the blood. Paroxetine, one of the most commonly prescribed antidepressants in seniors, blocks the enzyme that clears metoprolol. If your doctor added paroxetine for the depression that the metoprolol caused, they inadvertently doubled the metoprolol level in your brain. Fluoxetine does the same thing. The antidepressant prescribed to treat the side effect of the first pill makes the first pill work harder on your brain. How many pills are on your nightstand right now that were added to treat the side effects of the first pill? Your hands are cold. Your feet are cold. You have been wearing socks in July. If a beta blocker slows your heart, the reduced cardiac output means reduced blood flow to your extremities. Your hands and feet are the last places blood reaches and the first places it leaves when the pump slows down. The coldness in your hands is not poor circulation from aging, it is reduced delivery from a slowed pump. Your weight crept up, not from eating more, you have been eating the same, but metoprolol slows your metabolic rate by reducing thermogenesis, the heat-generating process that burns calories between meals. Senior women on metoprolol gain an average of 4 to 6 pounds per year without any change in diet. This has been studied, it is documented, it is almost never mentioned at the pharmacy window. You stopped wanting to exercise, not because you became lazy, because metoprolol blunts the exercise response that makes physical activity feel rewarding. The natural dopamine release that comes after a brisk walk, the lift you used to feel, the energy that came back afterward, is partially blocked. Exercise stopped feeling like it worked, so you did it less, so the weight continued, so your blood pressure crept back up, so your doctor increased the metoprolol. Margaret had gained 11 pounds in 4 years. She had been eating the same foods she had eaten her whole life. She told me this with a specific frustration, the kind that comes from years of being blamed, subtly, for a problem you did not cause and cannot control. Her previous doctor had suggested she watch her diet. She had been watching her diet. The pill was watching her scale.
I want you to do something right now while you are watching this. I want you to think of a movie you loved deeply, one you watched many times, one that lived in you. Now name the actor who played the lead, not the character, the actor. If that name came immediately, hold that feeling. Now try to name the actor who played the second lead in that same film. Did it come as fast? If you felt yourself searching, the name was there but not reachable, the tip of tongue feeling that used to be a moment and is now a minute. You just felt what metoprolol does to retrieval speed. This is not the same as forgetting. The information is stored. The pill slows the retrieval. Pharmacologists call this processing speed reduction. Neurologists call it subcortical cognitive impairment. Seniors call it, "I used to be sharper than this." Your doctor calls it aging. It is not aging. It is a lipophilic beta blocker sitting in the retrieval circuits of your brain every day for the past several years, slightly slowing every signal, slightly thickening every moment of thought. Now press the back of your right hand against your cheek. If your hand feels colder than your face, if there is a noticeable temperature difference between your hand and your face, your circulation to your extremities is reduced. That coldness is the same mechanism operating in your brain's microcirculation. The hands and the brain are both downstream from the slowed pump. You just ran a test your doctor has never run in your office visits. In 7 minutes, you tested your memory retrieval and your peripheral circulation. Your doctor checked your heart rate. Your heart rate is 58. Here is the question that made Margaret the most angry, and it should make you angry too. There is a class of beta blockers called selective beta-1 blockers with low lipophilicity, drugs like bisoprolol and nebivolol that do the same cardiac job as metoprolol without crossing the blood-brain barrier. They slow the heart, they protect against arrhythmia,
they manage blood pressure, they do the entire job description. But they do not dissolve in fat, they do not cross into the brain, they do not sit in the retrieval circuits, they do not suppress the norepinephrine that controls focus and motivation, they do not disrupt slow-wave sleep, they do not blunt the exercise response. These alternatives have been available for decades. The research showing metoprolol's brain penetration compared to these alternatives has been in cardiology journals since the 1990s. Metoprolol is prescribed at nearly 10 times the rate of bisoprolol in the United States, not because metoprolol is better, because it came first, because it went generic first, because it sits on the cheapest tier of every insurance formulary, because the drug representative who trained the doctor 20 years ago promoted metoprolol, because the prescription pad has the path of least resistance, and the path of least resistance is the drug that every other doctor is already prescribing. The cognitive cost of that choice is paid by the senior, not the system. Margaret sat with this for a long time. Then she asked me, if these other options exist and the research on brain penetration has been published for 30 years, why did my doctor put me on metoprolol in 2017? I told her the truth. Because it was first on the list, because it was cheapest on the formulary, because in a 7-minute appointment a doctor reaches for the most familiar tool, because familiarity in medicine is not the same as optimal, because the system measures your heart rate and celebrates 58. The system does not measure how many words you could not find last Tuesday. The system does not measure how many lunch invitations you stopped accepting because you were afraid.
The system does not measure the notebook on your nightstand. She was quiet for a moment. Then she said, 7 years. I have been carrying a notebook with my grandchildren's names in it for 7 years because of a drug that didn't need to be this one. Here is what to ask for at your next appointment. First, ask for a cognitive baseline test. Tell your doctor, I have been on metoprolol for several years, and I have noticed changes in my memory and word retrieval. I would like to complete the MOCA cognitive screening today so we have a baseline to compare against going forward. The MOCA takes 8 minutes. It is free. It is the test that catches subcortical cognitive changes that standard dementia screens miss. If the score is below where it should be for your age in education, you have data. Data changes conversations in ways that feelings do not. Second, ask for a sleep quality assessment. Tell your doctor, I take metoprolol in the morning and I wake exhausted despite sleeping a full night. I have read that lipophilic beta blockers can disrupt sleep architecture. Can we discuss whether the timing of my dose or a switch to a hydrophilic alternative might help? Hydrophilic. Use that word. Your doctor will know it. It signals that you have done your research. Doctors listen differently when patients arrive with specific vocabulary. Third, ask this directly. I have read that bisoprolol and nebivolol provide equivalent cardiac protection with significantly lower brain penetration than metoprolol. Given that I am experiencing cognitive and mood changes, I would like to try a supervised switch to bisoprolol for 8 weeks with home monitoring. If my cardiac markers hold and my cognition improves, that tells us the metoprolol was the source. No doctor can refuse a supervised 8-week trial when you are offering to come back with data. If your doctor says your memory changes are just normal aging, say this: I have been experiencing these changes consistently since beginning metoprolol. The timeline is specific. I am not asking for a dementia diagnosis.
I am asking whether a brain-penetrant medication taken for 7 years could be a contributing factor before we assign the label of aging to something we have not ruled out pharmacologically. You are not arguing with your doctor. You are giving your doctor a question they cannot answer without testing, and the test is free and takes 8 minutes. Never stop metoprolol on your own. A sudden stop causes rebound tachycardia that can trigger a heart attack. The switch must be supervised. Your doctor starts bisoprolol on the same day they taper the metoprolol and monitors your heart rate for 2 weeks. That is the safe protocol. That is what you are asking for. A supervised switch, not an unsupervised stop.
Margaret switched to bisoprolol 11 months ago. I want to take you through what happened, because this is the proof that what she lost was not aging, and that most of it comes back. Week 1, the metoprolol cleared her system over 4 days. By day 5, the beta receptor blockade in her brain began lifting. The lipophilic chemical that had been sitting in her retrieval circuits for 7 years was no longer being replenished. Week 2, she called me on a Thursday morning. She said she had been reading at her kitchen table the night before, and a word had come to her, a specific word, a precise word, a word she had been reaching for in conversation for 2 years, and kept landing on a blunter substitute instead. The word came immediately. She said it out loud to herself. Then she sat at her kitchen table and cried for 20 minutes, not because she was sad, because she recognized herself. By week 3, the afternoon fog had a different quality. It was still present, but thinner, less like a wall and more like a window with condensation on it. She could see through it. She could work through it. By week 4, her sleep study showed early re-emergence of slow-wave sleep. The sequences were not perfect, but the depth was beginning to return. She was waking at 7, feeling as if she had actually slept, not simply survived the night. By week 6, I ran the cognitive screening again. Her MoCA score had improved by 4 points. Not a miracle, but 4 real points in 6 weeks, points that represent actual retrieval, actual processing speed, actual construction of complex thoughts coming back from what was not aging but chemistry. Her daughter called her after they had dinner together in month 2. She said her mother had been funny again at dinner. Not performed funny, trying to seem okay funny, actually funny. The observation came back, the precise, unexpected observations that Margaret had made her whole life. That was her voice. That was the Margaret her daughter had known before the pill. It came back at dinner. Her daughter did not know why. She just said, "You were yourself tonight." Margaret told me that was the moment she got angry. Not at me, not at the pill, not at her previous doctor, at the years. She said, "I was told for 7 years that I was getting older, that this was what 70 looks like, that the notebook was just being careful, that the fog was just fatigue, that the cold hands were just circulation." She paused. Nobody asked what was in my pill bottle. By month 3, the weight loss began without any change in diet, 8 pounds in 12 weeks, released not because she ate differently, but because the thermal suppression from the metoprolol was gone and her metabolic rate had begun to recover. By month 4, she was accepting lunch invitations again, not because she forced herself, because the fear of losing words in public had eased. The words were coming, not every time, not perfectly, not the way they came when she was 50, but reliably enough that she was not afraid of conversation anymore. She went back to the restaurant she had loved and stopped going to 3 years earlier. She sat at her usual table.
She ordered her usual dish. She talked for 2 hours. She told me she did not write a single thing in her notebook that day, not because she forced herself not to write, because she did not need to. Her granddaughters' names came without the notebook. They had always been there. The pill had been sitting between her and the shelf where they lived. The pill was gone now. The names were there. And she cried again, this time in the restaurant, in a way she had not cried in 7 years. Not the stunned, quiet grief of slowly losing yourself, but the relief of finding out you were never gone. Do one thing for me right now. Think about the person you were before your current medications, before the fog, before the notebook, before you started sitting out the afternoons, before your family stopped expecting you to be the sharpest person in the room. If there is a version of you that existed before the pill and has not fully been present since, that gap is worth a conversation with your doctor. That gap is not inevitable. That gap has a question attached to it, and the question is, what if it's the pill? Subscribe before you leave, because the next video covers the one mineral that begins repairing the exact type of cognitive damage metoprolol causes, the kind that heals from the inside naturally, alongside any medication your doctor chooses. Subscribers see it before it reaches anyone else. If this video gave you something, a question to ask, a word to recognize, a version of yourself to look for again, leave a comment with how long you have been on metoprolol and what you have noticed, not for me, for the person watching after you who has been told for 5 years that they are just getting older. You might be the only person who tells them to check the pill bottle before they accept the diagnosis. Send this video to the person in your family who carries a notebook they should not have to carry. They deserve to know the notebook might not be theirs. It might belong to the pill.
This video is for educational purposes only and does not constitute medical advice. Never stop, reduce, or alter metoprolol or any beta blocker without direct supervision from your prescribing physician. Abrupt discontinuation of beta blockers can cause severe rebound tachycardia and may trigger a heart attack or hypertensive crisis. Any medication changes discussed in this video must be supervised by your cardiologist or prescribing physician with close heart rate monitoring during transition. The alternatives discussed represent general educational information, and individual medical circumstances vary significantly.